Hi everyone, good afternoon. My name is Florey Cruz-Serpa and I'm the Community Health Manager for Hackensack Meridian Health Mountainside Medical Center. That is our new name, or the good old Mountainside Hospital, as many of you know. Today's lecture is going to be on diabetes, so I want to go ahead and introduce you to Christina Vassallo, Nurse Practitioner for Mountainside Medical Group Endocrinology. Christina, come on over.
Okay, good afternoon, everyone. So I'm Christina, and as she had mentioned, I am the nurse practitioner at Mountainside Medical Group, the endocrinology department. So some of you might be familiar with the department. I work with Dr. Davis, Dr. Sherry. We have a certified diabetes educator there as well. So, as a team, we take care of all of our patients with diabetes. So today we're going to talk a little bit about understanding diabetes and also living with diabetes. So before we get started, in case some of you might not had any exposure to a nurse practitioner before, I'm just kind of going to go over what that is. So I am a nurse, but after being a nurse for some time, I actually went back to school, got an advanced degree, got a master's degree, took a national exam, and that allows me to have many of the privileges that a physician or another provider would have. So I actually prescribe medication, I develop diabetes management plans, I interpret labs, I see how people are doing with the diabetes, and I manage them independently. So that's how I contribute to our team. So an overview of some of the stuff we're going to discuss. Although we have a small group, so if there's things that you guys particularly want to address or things that you think are just way too complicated, we can kind of skip or focus on different areas. Feel free to raise your hand if you have a question. Some of it might be later in the slide, so if it is, I'll just tell you to hold the question and we'll get to it. Yeah? The office is actually 123 Highland, so it's like 1.5 blocks down the street. So, sorry. Okay, so we'll start with sort of a little overview of diabetes, understanding diabetes. What is it? What are the different kinds of diabetes? How do we diagnose it? What are the risk factors? And who do we decide to check? And then after that, we'll talk about living with it. One of the main things we have to touch on a little bit is what are the consequences if we don't control this or if you don't know that you have diabetes. And then we'll talk about what are our goals for good diabetes management, the treatments that we use, which always include lifestyle, but also the different kinds of medications, and then just some self-care and health maintenance tips. So diabetes, what is diabetes? So this is very important for understanding how to control it, is understanding what it is. So diabetes is essentially too much sugar in the blood. Okay? So everything that we eat gets digested and it gets turned into sugar, or glucose is what you might hear us call it. And then that glucose goes in our bloodstream to every organ in our body, every cell, and that's the fuel, that's the nourishment, that's how it gets energy. So what happens is that it travels everywhere in the body, but to actually get to where it needs to be, it needs a hormone called insulin. So that glucose can be circulating everywhere in your body, but it can't actually get into the cells unless it has insulin. Insulin is made by the pancreas, and that's where the kind of the fundamentals you need to know to understand what diabetes is. So diabetes is basically a problem with the insulin. So there are different types. So sometimes diabetes means not having enough insulin. You don't make it anymore. Your pancreas doesn't work, or something happened to it. And sometimes diabetes means that you're resistant to insulin. So you actually make a whole bunch of insulin, but it's just not doing its job. So when the insulin can't do its job, or you don't have enough of the insulin, you get really high sugar in the blood. It doesn't get into your muscles. It doesn't get into your organs. So you don't get that fuel. So diabetics often complain about feeling tired all the time. And it's really because their bodies aren't really getting the nourishment. They have all the sugar they could ever want inside the bloodstream, but it's not getting to the crucial places it needs to go. So we'll talk a little bit about the difference. Most people have heard of type 1, type 2, and gestational, or diabetes when you're pregnant. So we'll just kind of go over those a little bit. And then I kind of want to just put on your radar that there are even, in fact, other types of diabetes in case you ever hear these things. So type 2, that is the most common kind of diabetes, the most prevalent one that we have right now. About 90-95% of the people that you know with diabetes are considered type 2s. And type 2s start off with that resistance to insulin. So their bodies do make the insulin, but for a number of reasons, the body resists it, so it doesn't work well. So the body at first, it tries to compensate, and the pancreas produces a whole bunch of insulin, lots of insulin, 2-3 times what a normal person would need of insulin. Eventually, the pancreas gets tired, and it might then stop producing any at all. So you're resistant to it, you produce a whole bunch, and then in the end you end up where you're not producing very much at all. And that's what's interesting, because in the course of a type 2, you might end up in the same place as a type 1. A type 1, from the get-go, they basically don't make any insulin. It's an autoimmune disease. What an autoimmune disease is that the body has made a mistake, and it thought that the pancreas was not supposed to be there, and it's trying to destroy it, and it's trying to attack it, as if it were a germ or a foreign object. So type 1s have damage to their pancreas, and they can't produce insulin at all. And then type 2s can end up in a state where they don't produce insulin at all. So for those two reasons, you can see why we actually do end up using insulin in either one. So what we're really checking, whichever kind of diabetes you have, is do you currently have insulin deficiency? Are you deficient? Are you not making it for whatever reason? And then gestational diabetes is completely separate. It is related a lot to insulin resistance, and it does put you at risk for future diabetes. Unfortunately, we'll talk a little bit about that. But is different from the other two. Typically does resolve after childbirth, but it can come back as type 2 diabetes later in. And then there's these other kinds, just to kind of be put out there, to know that sometimes it's not easy to figure out where you are in the type 1 or 2. There's something called LADA, or latent autoimmune diabetes. And what that is basically a really slow type 1 is how it's been described before, where at first you think you're just having a little pre-diabetes, you think you're having a little bit. They try the pills, they don't really work, and then little by little you very quickly turn into a person who doesn't make any insulin at all. And when you don't make any insulin at all, really the only treatment for that is to replace what you don't make. And then there's some MODY, which is another kind of genetic thing. So just to be aware of, unfortunately it's a spectrum. So it is hard to get a handle on the diabetes. Okay, so how do we diagnose it? A couple of different ways. A fasting blood sugar, so that's the machines that we probably have here today. It's just a pinprick, and we just need 1 drop of blood. And if you're fasting, meaning you haven't had anything to eat, and it's over 126, that's consistent with diabetes. At any time during the day, if we were to check someone's sugar right now and they were over 200, even if you have eaten, it should still never go over 200, and that is also diabetes. An A1C. So an A1C, I don't know, has anyone in here ever heard of an A1C, what that test is, that blood test? Okay, a couple people. So what an A1C is, it's a blood test that we take when we take a sample of blood from the vein. And it can give us an average of how the blood sugar looks over the previous 3 months. So what's good about that test is it doesn't matter what you ate that day, doesn't matter what you ate that week. It's going to tell us overall on average how well your sugar is controlled. It does that in a neat way. So our body makes red blood cells, and those red blood cells get recycled every 3 months. And what happens is the amount of sugar that happens to be in our bloodstream kind of sticks to the outside of that red blood cell. And so we just measure how much is there. If they're really coated sort of with sugar, then you can kind of tell that there's been a lot of sugar in the bloodstream over the last 3 months. So that's kind of a simplification of how we tell. So those numbers, though, what is considered diabetes is over 6.5. So if you have a number over 6.5, that is in fact diabetes. People are always curious, well, what does 6.5 mean as far as when I actually check it on the meter? Because those are the numbers we're most familiar with. And we know those go from hopefully 80 to 180 and that's it. Or sometimes a little lower, a little higher, but basically that range. So over here is kind of just a little chart that shows you what it means. So a 6.5 is about 140. So that means we want most of the time that to be the highest number you would ever see. Now you get 140 by sometimes being 80, sometimes being 130, sometimes be a little more than 140, but on average, you don't go higher than that. You'll see that truly normal is even much lower. Truly normal is 5.5. That's 110. That's someone whose sugar is not really going higher than that on average. Okay, there are some times after meals when it goes a little higher than that, but the average is much lower. And then there's the oral glucose tolerance test. We do use that with pregnant women, and that's when we give you a sweet drink and then we check your sugar. And if it's over 200, just like that anytime check, then that's considered diabetes as well. Just a little note about pre-diabetes is a term that is going around there. You might have been told you have pre-diabetes. What does that mean? That's basically these ranges. So an A1C of anything over 5.7, a fasting sugar of anything in that middle range, 100, 125, and the oral glucose test through those numbers. Yeah. Hyperglycemic, yep. So hypo means low, your sugar's low, and hyper means your sugar too high. So yeah, it can be consistent with being hyperglycemic. I'm sorry. It's just that I'm short, so behind it. Okay. Yeah.
So hypo, because they told me I'm hypo.
Okay.
So it's low.
Okay.
And so they said it could go into diabetes, but that's not.
So that's a very interesting case. Sometimes that can just represent that your insulin does kind of funny things. Because perhaps you were reacting to something that you ate and then you made a lot of insulin and you ended up too low, that your body's sort of regulation is a little bit off. And some people who have some of that can end up with diabetes later as well. So it depends in what context. You know, it would be really interesting to see when do you have these low episodes and what is your average? What's your A1C would be a better sort of indicator of what your risk is. Okay? So, but there are people who just show some problems with regulation of, you know, where their sugar should be, that it is another sign that perhaps they'll get diabetes later on. Okay? But of note, just to finish that, is that there are other endocrine conditions that do cause low blood sugar. So that's something that, you know, you'd have to more comprehensively talk to your doctor and look and see if there were other reasons that it might be going low. So we do have some other, so endocrinology, probably should have started with this, is a study of hormones, and there's lots of them. And that's how come we end up being diabetes specialists, because obviously insulin is a hormone. But there are a lot of hormonal things that can kind of go awry, that can cause low blood sugar. So, you know, you might want to consider in the context that it might be something else as well. Sorry. We're going to talk about that. Hold that thought. That is definitely something that we're going to address today. And you've described it perfectly, and there's a reason that you feel that way. Okay, so first of all, who should we be checking for either prediabetes or diabetes? So basically anyone over, and this is good information for if those of you have family members out there who never go to the doctor, who haven't gone to the doctor in 10 years, just other information you can tell them of, hey, maybe you should have your yearly physical. So anyone over 45 should have that yearly physical and have that A1C test to see if they're diabetic. Anyone with these risk factors. So if you've ever been told you're pre-diabetic, if you've ever had gestational diabetes, if you've ever had a really big baby, 9 pounds or more, if you've ever had any of the problems with your sugar being in that those borderline numbers we talked about before, or if you have any other conditions that would make having diabetes bad. Like if you have hypertension, you should be keeping an eye, make sure you don't get something else at the same time. If you have cholesterol, if you have heart disease, and then some other conditions, we know that people who have these conditions just more likely get diabetes, like a condition called PCOS, which is a hormonal imbalance women, and some others. And then anyone who is overweight or inactive. Being inactive, independent of whether or not you are overweight, if you're just sort of sedentary, is a risk factor for developing diabetes. And then certain ethnicities are actually at higher risk than others. Okay, so how many of us have diabetes? How prevalent is it? So about 30 million people. That's about 9.4%. So 10% of our population, 1 in 10 almost, have diabetes. That's how much. And it's actually doubled. There was a doubling from about the 1990s to about 2008. How many more people? And a lot of those people, up to 23% of them, don't know that they have diabetes. These might be people that maybe at one time, maybe they had gestational but they never followed up. Maybe they were told they were pre-diabetic but they haven't been there. Or maybe they're just not really paying attention to their health or the signs. There are a lot of people out there that still don't know. The incidence, and this is related to type 2, I should mention, because we did talk about type 1 is much rarer. It's about only 5-10% population. So the amount of people with type 2 increases as people get older, and those over 65, it's about 1 in every 4. 1 in every 4 people over the age of 65 have diabetes at this point. Now, pre-diabetes, this is a big one. I left this little fact at the bottom. So when you have, so we'll talk about from 5.5 to 6 or 6 to 6.5, right? There's two different things. Between 9 to 25% or 25 to 50%. So when you're in that pre-diabetic range, you have a 50% chance in the next 5 years you're going to develop diabetes. So those are critical. Those are really important times that start having good conversations with your healthcare providers of what things you can do in your lifestyle to try to delay or prevent it. Some people with pre-diabetes we know are going to get diabetes. It's just a matter of when, and when is really important, because the longer that we keep that from appearing, the less chance that you're ever going to have complications from it, that anything bad is ever going to happen from it. So it's really important to be aggressive when you note that someone has that in-between sugar level to really get them, involved in looking at the things that they could change. Okay, so this is why it's important to have a really good plan when someone does have diabetes. So diabetes is the 7th leading cause of death in the U.S. 2 out of 3 diabetics, unfortunately, pass away from heart attack and stroke. So when we think of diabetes, a lot of people think about blindness and eye troubles, which is true. It is actually the leading cause of blindness still among adults is from diabetes. And we do think about people who, go through amputations and lose their feet. We think about those things. And we do think about kidneys and people ending up on dialysis. Those are things that we think of. We don't often think about heart attack and stroke. That's not one that comes to mind. But 2 out of 3 diabetics, that's really the problem that they're having. So when we think about treating your diabetes, we're not just thinking about making that number normal. We're thinking about what else is going on with you that is going to lead you to possibly have a heart attack and stroke, and how can we treat those all at the same time? We have to look at the same picture, because this one thing is giving you a really high chance of getting 2 other things. So what else do we need to do when we take care of your diabetes, besides diabetes, to make sure that you're healthy? So that's the bad information. The good information on the left side of the screen there, or on the right, I guess from your perspective, is that we've gotten a lot better at these things. So over at this top, this is where it was in 1990 of all the people suffering from the complications and the number of people per 10,000, and you can see it has dropped. So we have better detection techniques, we have better ways to monitor people, in some ways we have better medicine. I think we're getting more acceptance of medicine in the community, especially the ones that are injectable, and we'll talk about why there's a lot of resistance to that. And because of all those reasons, the numbers are going down. So you can see that some of these things have cut in half. Okay, so management goals. What are we trying to do? I already kind of talked about this a little bit. So number 1, of course, we want your A1C to be at goal. So we want it to be below 7. We do want your blood pressure. If you have diabetes, sometimes when you don't have anything, you just have a little bit of blood pressure, we let you get away with it. But if you suddenly get diabetes, now we want to fix both things. Okay, and that's why people are always confused. They're like, I don't understand. I came in here, I had a little bit of sugar. My next appointment, I came in here, and now you want me to start a diabetes pill, a cholesterol pill, and a hypertension pill. And that's exactly because of what I talked about the heart attack and stroke, which is that once you have diabetes, you are so much more at the risk for those other things. We can't let you get away with anything, unfortunately. We have to treat all 3 of those things at the same time. So it is very common. You come into me, and you're not all of a sudden getting one thing, but we're going to treat all of the little things, all of the little, because we want them to be perfect. So we want your blood pressure to be under 130/80. And we want your bad cholesterol to be at least under 100. And then always a goal of ours is to individualize the plan for something that you're actually going to follow. Okay? Something that motivates you. And something that minimizes side effects. There's not many medicines that come with 0 side effects. Some of them come with nice side effects, like weight loss or increased energy. Some of them come with bad side effects, like nausea. But we're going to try and minimize those bad side effects as much as possible when we come up with a plan. Okay, so how is it treated? So number 1, especially in that pre-diabetic zone, is lifestyle habits. So that can be anywhere from, first is movement, physical activity, exercise. We can call it any of those 3 things. For some people, the goal isn't really physical activity or exercises classes, it's just movement. It's doing the basic movements throughout the course of the day and sitting still as little as possible. Teaching people moderation with eating and drinking, and teaching people to monitor and know what numbers they should be looking out for, so if their diabetes starts to change, starts to get a little worse, we can get ahead of it. Medications are always a big part, and weight loss, independent of the other things. So I separate out lifestyle habits and weight loss because you can actually get an improvement in your diabetes, in your blood pressure, in your cholesterol, just doing the lifestyle habits, even if that number never changes. even if you don't have any weight loss. Even if you stay the same weight loss, but you suddenly start walking a mile a day, you will see your A1C and your blood pressure go down. So those things are kind of separate. I don't have people try and do those habits because I want them to lose weight. You can be a thin person coming to me with diabetes, and I still need you to be moving as much as possible, to be moderate with what you're eating and drinking, and to be monitoring yourself, okay? So, movement, physical activity. So there's lots and lots and lots of ways these days to be active, and it is really important. One of the things that encourages some people is that it really just takes a small change to be able to make a big difference in numbers. So small changes can be just regular movements throughout the day. I like to think about this as taking all the conveniences. We have all these conveniences now. Sometimes if you just take some of those out of your life, that can be enough to make things easier. So taking the stairs, parking further away from where you're going. When you're in your house, simple things like if it's a cold day, we want to go home, we want to heat up some soup that we made the day before, we pop it in the microwave. You know what you could do? Bend down, get the pot out, put it on the stove, put your soup in, heat it up on the stove, stand there and stir it, pour it out, and then wash your dish. All of that takes activity. You know, all those things that we used to do, not putting it in the microwave and then putting it in the dishwasher. So sometimes if you just go back to doing things the old-fashioned way, you don't have to then go to the gym for 30 minutes every night. You can just do your regular things. So that's, some basic things that you can do. Involvement of friends and family. If you do something with someone, with a friend, with a family, there's accountability. You're going to motivate one another. You're going to want to be there for one another. You're more likely to follow through. I have many, many patients that started some kind of group or program or dance or class or yoga or walking group, and they are now lifelong friends because they started doing something together and that they're there for each other. And it's not just the walking, but it's the being able to talk when you're walking and talking about the things that you're going through that also helps. And that kind of takes care of two things at once, stress management and your activity, because talking to someone about what's going on is going to bring everything down. So forming those relationships and being out in the community is really important. And then for those people who are still working, work cannot be your only physical activity. And I know this is hard for people. A lot of us have very active jobs. I was a nurse for a very long time running around an emergency room. That can't be it. When you're at work, you're kind of balancing a couple things. There's obviously, it's a little bit more of a stress thing. It's not a relaxing kind of exercise. And also you do it every single day. Anything you do every single day, your body gets used to. And you need to continue to challenge your body. If you want to keep your body healthy, you keep doing new and different things. If any of you have ever read any advice about how to keep your mind fresh, how to keep your mind healthy, what do they say? Do new word puzzles, read new books, go to new places, have new stimulus. Your body is the same. Your physical body is the same as your mind. So if you want to keep your body healthy, you have to do new different things. So going to work, even if your work is being a fireman, running around, doing the same thing every day, isn't going to keep your body new and stimulated. So you need to try different things. There's a lot of different systems of how much exercise we tell you to do. But the thing that's really important to know is that every step counts. Every time you're not sitting. I would say the only goal I really try and tell people is please don't sit for more than 30 minutes straight, ever. Just get up and move. Even if it's just getting up and changing the channel on your TV, don't sit for more than 30 minutes. The bodies, if you pay attention to young children and you see how they are, have you ever seen a little kid sit for 30 minutes straight just because someone didn't tell them to do that, right? No, they're constantly moving and they're healthy and nothing hurts because they're constantly moving. So try and be like that. Find a reason to just get up. Even if it's walking from one side of your house to the other, every little step will add up. So that being said, I think that's a much better natural approach to take to being active in our lives, to kind of go back to the way we used to do things, spend more time with our friends and families in ways that keep us active, and knowing that as long as we're just not sitting for a long period of time, that is enough for most people. For other people whose goal is weight loss, yes, you should try and intensify. And yes, you should do as much as you can with a goal of at least 30 minutes 3 to 5 times a week. Okay, and that could be anything, and there's different levels of things. And obviously, the older we get, we want to think about things that maintain our muscles and are good for our bones and maintain our balance. Okay. Yes. 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 You know what? I think, let me see which one that is linked to. A lot of these, oops. You know, if you actually, do you have internet at home? By any chance? Okay. So we can probably, yeah, that's what I was going to say. We can blow it up and print it out, because a lot of these things are available if you Google and type them in, or if you have a family member that visits a younger person who has, I'm sure, not saying that a lot of people don't, but sometimes that they can just pull that up for you. So, okay, so food. I am not a nutritionist or a dietitian, so I'm not going to give you an exact meal plan here. I'm going to give you the advice, the general advice that I give all of my patients, which is a place to start. There are going to be some people that do benefit from seeing a dietitian, and actually the certified diabetes educator at our practice is also a dietitian, so that's a lovely combination. That is not what I am, so I'm going to give you the basics to just kind of get started. The thing that I've been recommending for a very long time that I think is very effective as a place to start is just the plate method. It's very simple. Has anyone ever heard of the plate method before out there? So what the plate method is, as you can see from some of these things, is you divide your plate. Half of your plate is vegetables, a quarter of your plate is starch, a quarter of your plate is protein. So there's a couple examples up here where breakfast, you have a quarter of it, your protein is your eggs, a quarter of it is your potatoes, and then some asparagus on the side as your vegetable. Down here for a dinner, a quarter, these are different kinds of vegetables, some kind of greens with some carrots and string beans. A quarter is some chicken, a quarter is some rice, and same thing you can see repeated on the other side. I think that one is a lunch example with some salad and some tuna fish and some toast. So if you just portion your food that way, you can pretty much eat any of the things that you like. So obviously this doesn't work for every kind of food out there, because some breakfast foods are like cereal, and you probably are not going to eat like a bowl of lettuce with that in the morning, but you can fit that in. If at least twice a day, I do believe your plate should look like this. So the vast majority of us don't eat enough vegetables, and I don't know when that happened, but we don't eat enough vegetables. I have patients that I ask, when was the last time you ate a vegetable? And it can honestly be 1 to 2 weeks ago. And that is not good for your health. And not just not good for your diabetes, it's not good for your colon, it's not good for your cholesterol, it's not good for just making sure you're getting all those vitamins and minerals that you need to feel good. So, not being a dietitian, I'm going to give you some basic advice. So, 1, eat real food. Okay? Real food doesn't have labels on it, doesn't have all these chemicals and preservatives on it. Real food is things that you make for yourself. Making real food also counts as activity. It takes a long time to just make dinner. Just stand there, you wash all the foods, you chop them all up, you put them in, you stir, you wait for them to cool, you put it out on the plates. So making real food actually has 2 benefits. Eat the foods that you like. Okay, there's no magic food out there. There's no magic bar, none of those things, those processed things, none of that. Eat something that you actually enjoy, and just eat smaller amounts of it. Pretty much any food, if you come in and we talk about it, I can figure out how you can still enjoy that food if you're willing to do less portions. Eat more vegetables. I think that everyone would benefit, and we'd see a lot less obesity, diabetes, everything, if everyone got a half a plate of vegetables twice a day. Half a plate. Go ahead. Yes, that can count in it. So it's not ideal, but sometimes we do have to replace meals, and we have to have a snack. So it depends. What does the rest of your day look like? Some people, when they are away at work, they don't have the ability to bring their lunch, and they don't have access to healthy things, and that puts them in a real bind. So I do say, okay, we know lunch is kind of going to be a throwaway. So we can always do at lunch a couple things to make it better, which is make sure our beverage is good, because usually we have access to water. So don't have the lunch choice that's bad that you have access to and then pair it with a soda or an iced tea or something that has sugar in it. Make sure that your beverage is good with lunch. Try and take a walk if you can after lunch. And then the other 2 meals in the day, follow these simple rules. For most of us, maybe that happens once a day where we can't do the things, eat the way, and it's typically lunch because we're out away from the house. But we can really focus on those other 2 meals. A lot of people, you're going to get a lot of good nutrition if you can just focus on just 2 meals a day being good. And if you have to eat a lot of your vegetables at dinner, that still is of a benefit. So you can have a much bigger a big plate of grilled vegetables, a big salad, whatever else it is, to get more of those vegetables. So a lot of the times when people come to me and we start talking about diabetes, the first thing I'm talking about is not what foods am I taking away from them. I'm like, how do I get you to eat more of the things that will keep you healthy, more of the vegetables that will keep you full, that will keep you away from being hunger because they fill you up, will give you vitamins, and will keep you nourished. So I'm starting to talk to them about how do I get you to, as a start, to eat some kind of vegetable every single day. Now, this might start to touch on the question you had. Can you remind me of the question that you had before? You were saying you feel hungry, right?
I'm completely exhausted.
Okay.
I can just sit and go to sleep.
Gotcha. Okay. So 2 things could be happening there. One of the things is that if your sugar is running a little high and your body is not appropriately handling the sugar once it digests it, you're experiencing kind of what I talked about in the beginning, which is that you digested the food, you put the sugar in your bloodstream, but your body hasn't been able to get that sugar because of a problem with insulin, either being resistant or a little deficient or something. It hasn't been able to actually deliver that sugar into the cells, into the muscles, into where it's supposed to be. So that's a very confusing state for the body. The body knows that it has gotten fed. It can tell because it gets signals from the stomach. So it is waiting for that energy and that nourishment, and it doesn't come. And so it's also tired because it was expecting to be refueled and it didn't get anything. The other thing that can happen for some people is if they eat very, what we call simple carbs, so if you eat something that's just very processed, like white bread or white rice, and you don't combine it with anything else, or you don't have enough protein, sometimes what happens is you get a little exaggerated response to it. So your body can still make insulin. It says, oh, look, there's about a lot of sugar headed my way. Let me make a lot of insulin really quick. And it kind of overdoes it, and it makes too much. And you actually end up with a little bit of a low sugar. And a low sugar will also make you tired because it's the same kind of scenario in both cases. A low sugar, there's not enough sugar in the muscles and where it needs to be because there's not enough sugar in the bloodstream. A high sugar without insulin, there's still not enough sugar in the muscles and where it's supposed to be because it can't get to where it wants to be. So it might be some of those things that you either go in full low afterwards or you're still staying a little bit high. Also, in general, the whole insulin resistance is a challenging condition, and it is associated with other metabolism problem, with a sluggish metabolism, with feeling more hungry. And it is because of this, because the body keeps thinking it's getting food, and then it feels like it got tricked. So what does it do? It stimulates your appetite. And this is why I don't know if anyone's been paying attention to the news that we found now that, remember all those diet sodas that we thought were great? And they actually end up making people heavier? And why do we think that is? The body got tricked, right? The body tasted something sweet, got something sweet in its stomach, thought it was getting food, and it didn't get it. So the next time, it's going to make your hunger signal stronger. It's going to ask for more. So that is the trouble. So that is where good nutrition and some of the things I talked about, making sure your body has all those nutrients, making sure you have all that good nutrition helps. Incorporating exercise, and if you are diabetic, getting your sugar into a normal range. A lot of that tired feeling afterwards is because of a mismanagement of the sugar and not ending up where you're supposed to be after you eat.
How about the fruit?
Fruits are actually okay, in moderation, and it depends where you are. So fruits are a tricky one. So vegetables, eat as much as you want, fine, vegetables are great. And the preference obviously is for all the vegetables that grow out of the ground, because the ones that are starchy that grow in the ground, so in the ground is, potatoes, yucca, sweet potatoes, all those kind of things. Growing out of the ground is, and even carrots obviously grow in the ground. Going out of the ground, lettuces, tomatoes, zucchinis, all those things are less starch. So that's kind of a quick trick to remember which ones are starchier and which are not. So if you grow in the ground, you're starchier, a little bit more moderately, you eat those. If you grow out of the ground, go ahead and have more of those. There are obviously exceptions, but for the most part, that's how it works. So, fruits. Anyone who is a pre-diabetic or just has a reasonably controlled diabetes can have fruit. That's fine. And we don't even really restrict fruits, even if your diabetes is not as well controlled. It depends on portion size. Everything is going to come down to how much of the fruit are you having. So some people might not be able to eat a bowl of grapes. That is just too much of them. But they can have a handful of grapes. It depends on how sweet the fruit is and how your individual body reacts to it. So fruit is healthy in the fact that it has fiber, it has water, it has nutrients, it has minerals, and it nourishes us. 2 pieces a day or 2 portions, because some things don't come in pieces, is reasonable for the vast majority of people as just starting advice. If it is all you do, though, to try and keep yourself from not eating, it's just snack on fruit all day, that's not going to be a good habit. If you happen to be particularly sensitive to one fruit, and we can talk about how to tell when a person does have diabetes what makes their sugar exaggerated. If you happen to be particularly sensitive to one, maybe that's something you only have on a special occasion, and you choose some of the other fruits for your daily fruits. So that's physical activity, and then we talked a little bit about the food. Oh, a couple more things about the food. Drink mostly water. So we did mention about the diet drinks. So the diet drinks, they're not going to cause a spike in your blood sugar if we were to measure it, but they will at the end of the day make you weigh more, and the weight will make the diabetes worse. So if you can avoid them, avoid them. If you need them as a crutch till you get onto water, that's fine. Tea, coffee, unsweetened things, those are also good. And then one of the most important ones, eat treats only at celebrations. We should really all go back to that. And if we think about how long it used to take to make some of these delicious things, like a cupcake, like a cake. I mean, if we think about our grandmothers baking these things and how much effort it took, you were not having those every day after school. You were not having those once a week. You were having those for birthdays, for holidays. Maybe someone got a new job and you spent the time to do that, but that certainly wasn't every single day. We've really seen a lot of problems once we have these convenience stores where it's a wall of sugar beverages and all these packages of cupcakes and treats that will last for the next 10 years. That's where the problem comes in. If you have, in a celebration, you have to be honest with yourself. The celebration is whatever you consider a celebration. There are reasons to randomly have things to celebrate and be excited about. And you can have treats during those times. But otherwise, in your day-to-day, we really should be avoiding them. Most of our history, we have not had access to those things, and people are thinner and healthier in some respects. So, go ahead. I am. Yeah, dessert is a treat. So I say treat because of the fact that some people they have that sweet tooth, and for them a treat is dessert. For some people it's chips, it's salt. So I mean any kind of treat. Because those salty, we know if you think of it as, ooh, I shouldn't have this, or ooh, that really tastes good, that is a treat for you. That is not something that you're just like, okay, I'm eating this every day. Everyone knows what a treat is. So a treat for you, if that's ice cream, yeah, only have that for celebrations. Now, can other people get away with eating ice cream, having dessert every single day of their lives? Of course. Can some people smoke a pack of cigarettes every day for 30 years and get away with it and not get cancer? Yeah. What are the risks associated with those things? One is lung cancer and one is diabetes. So you have to, decide what you want to do. I know, it's hard. And these are optimal health things. And obviously people who already are showing signs of having a little prediabetes, these are the rules you should really try to follow as best as you can. If you have none of that, nothing, who am I to say if that's how you want to live? That's up to you. But that ice cream habit, it does have salts and fats and cholesterol and other things, and the body doesn't need it. Your body, we're not giving our body enough of the things it really does need. There's not enough room in the diet. If we were really eating all of the vegetables that we need and all of the proteins that we need and the whole grains that we need, we wouldn't have a lot of room left over. So the sweets are actually probably cutting into all the other good stuff we should be filling ourselves up with. Yeah. A fruit. Every day you can have a fruit. That's a dessert. That used to be a dessert. There used to be a time where being able to get oranges in the winter was a treat. They couldn't get those things. Now think about it now. We have all this shipping and we get all these fruits from warm climates. Do you think 3 generations back, there weren't bananas if it was wintertime? There weren't any of these kind of treats. So, these are also special treat things. People used to get really excited about having those kind of things in the winter when it first started coming around. Now we have even a next level of innovation where we can have these processed foods and these sugary foods that are available anytime. But those turned out to not be as good for us. So, yeah. Yes. This is a hard one for everyone. This is a hard one for my father, who does have diabetes, who I've explained several times cannot have ice cream every single day. And you know what happens? He listens to me for about 3 months. His blood test comes back perfect. He's like, I'm fine. He goes back to eating ice cream for 3 months. His blood sugar goes up. And he's like, oh, I shouldn't do that. And then he goes back down. And that will probably work for him for a very long time, because it doesn't seem like he's one of the people that kind of trend this way. And that's the frustrating part about diabetes. This is a whole other topic I could talk about. Why does diabetes go differently for different people? Some people, every time you go in, it seems to get worse. Some people, it only really goes worse when you're not doing the things you're supposed to do. And some people, it stays the same no matter what. They could not be doing the things, they could be following the diet, they could be doing whatever, it just stays flat. That's a whole other genetics frustrating thing. But he seems to be one of those flat people, but still, the up and down, I should say, with the diet thing. But still, you should not be having ice cream every day. So yeah, optimal health, no. Treats are for celebrations. And you can, and ideally you make it your own. Yeah, absolutely, yeah.
What about bread? Is that separate, or is that something you can have?
Bread you can have. Yep, there are no off-limit foods. As I said, it's really better that you eat the things you would normally eat and find a way to reduce them and eat small portions of them. I'm not going to tell someone who, part of what they eat is rice and beans or pasta or sandwiches that they can never have those things again. Ideally, they'll still be able to have them daily if they reduce the portion size enough, but sometimes we have to say maybe that's an every other day kind of thing. So it depends on the individual. I've had some people that, it depends on the individual for 2 reasons. 1, how your physical body reacts to it, and 2, how your mind reacts to it. So I've seen, to overgeneralize, 2 kinds of patients. There's one kind of patient that is going to be mentally happy if they get to still have the same kind of food they're used to, and they're willing to just reduce it. If they can just have a couple bites every day, they're totally happy. I've seen other kind of people that if they've tried that strategy, every time they have a little bit, they overdo it. And they're like, and then they go and they see someone else and they're like, you know what? They told me to just give up rice and now my sugar is perfect. And it would have never occurred to me, because that is just not what I personally feel, that's not how I would want to live, to say to someone, completely eliminate this food. But for some people it works, because they have sort of a, they have that personality where they get one bite and they want more. So if you know yourself and you're I get one bite, I know more, you might have to give up things entirely. So, and this is the same advice I give people when they try and quit smoking, right? The vast majority of smokers can't just have one, can't be a casual smoker, can't do it every once in a while. Once they have one, that's it, they're back to smoking. So I tell them, before you quit smoking, you have to know that that's it forever. And yes, I know there are people out there that exist that are able to have them every once in a while, and they can keep on going, but you can't assume you're going to be one of those people. You have to be ready to never have one again. And for some people, they have that tendency. If they see it, they want it, and they want all of it. So take it out of the house, and you have to give it up. Other people, if they're like, oh my God, I can't, they're just depressed. They're very unhappy if they can never have this one thing again. But they're willing to limit themselves. They're like, I need chocolate every day. And I have some diabetics that eat a piece of chocolate every day. They break them up into these little bars. They have a square about this big. And they have it every day. I don't necessarily want them doing this, but for the balance of their health, if they're doing all the other things I ask them to do, they're drinking all the water, they're doing all the activity, all their numbers are beautiful, and they really can control themselves and have that one little bit every day, why not? Why wouldn't they have that?
I have a girlfriend from Africa.
Yeah.
And she said when they were growing up, the Hershey bars?
Yeah.
And it's like in 12.
Yeah. Yep.
Her whole family, it was about 8 of them.
Yes.
Her mother would take one Hershey bar and give everybody a square. One square for the whole family.
Yeah.
That only has to like maybe every other day.
Exactly. Exactly. So if you think how much sugar, so if we think about insulin resistance and our pancreas getting overworked, think about how much, and that happens when our bodies are exposed to sugar. Think about how much less she was exposed to sugar because of those habits of her family. How much less in her lifetime. We think about lifetime risk. Every time you're exposed to it, let's think about it like an overdose of sugar. Your pancreas has to kind of do its job and kind of try and work and speed up. So every time that happens, that kind of increases your risk. A lot of people, it's strange. Diabetes runs in families, but not everyone gets it. And a lot more young people are getting it. And why is that? Because even though you have that genetic potential, there has to be a couple things to happen to you to then weaken it so that it kind of comes out. So that's why we used to see people are like, oh, there's diabetes in my family, but that just happened to my grandmother when she was 80. But then, my mom got it when she was 60. And why am I 40? And that's because of how much life has changed. So before, maybe that grandmother only had exposure to very little sugar throughout her life, and she did a lot of physical activity. Maybe the mom had a little bit more, but not as much as the grandmother. And then now we have the younger people today, who a lot of it is screen time. A lot of what they do, how they socialize is just this. There's a lot of sitting down, and there's a lot of easy foods. There's not a lot of just, I know this sounds silly, but home-cooked meals and regular snacks, and just telling them to, sorry, be hungry and wait for dinner, because there's always something you can grab. Kids need to learn to be hungry again. There's nothing wrong with being hungry and waiting for food. Exactly. Okay. So monitoring and knowing your numbers. So for those of you who do have diabetes, we'll just go over some numbers very quick. Fasting in the morning before you have anything to eat, that number should be less than 110. 2 hours after you eat, so right after you eat it's going to go up. 2 hours afterwards it should go below 140. Before any meal, randomly, we like it to be between 90 to 130. So those are kind of the targets. And this is what we talked about a little bit of, how do you know how much or what you can have of something? This is a good test. It's the 2-hour test. So have your normal dinner, and if you're like, can I really have this? And then check your sugar 2 hours later. If your sugar 2 hours later is 200, the next day, try and make that portion a little smaller. Again, check 2 hours later. If it's still too high, make it a little smaller. If you find that you have to make something totally disappear, then maybe that's something you can't have every day. If you find that, oh, you know what? If I just have just 1 scoop of pasta instead of two spoonfuls, my sugar stayed perfect under 140. You can have that forever, and now you know what works for your body. Because unfortunately, the same type of food in the same quantity affects everyone differently. So it's really hard to know. And that's why diabetes is such a personalized thing, and it's a lot of going back and forth. So, one person might have a whole plate of pasta and their sugar doesn't go up. The other person, their sugar goes up to 300. One person might have, a potato every single day, and the other person just takes a bite of potato and their sugar goes up. So whatever your body happens to be able to process, and that has a lot to do with different things, and how it metabolizes it depends on what kind of food you're eating and the different quantities. So the 2-hour test is a good way to see which things you might want to try and think of to get rid of in your diet or to reduce in your diet. ABCs, so we talked about this a little bit before, because remember, we're not treating you just to get a number down. We're treating you because we know bad things happen to you because of the diabetes, or more frequently because of the diabetes. So we're looking at the other things too. So we're looking at blood pressure, and we're looking at cholesterol. The other thing that is just generally helpful is if you're taking medicine, know your doses and carry your list. Okay? Because you never know when something's going to happen, or when diabetes is suddenly going to go awry, and you need to find someone to help you know how to adjust these things. Okay? Stress is obviously linked to high sugars, not sleeping well, any kind of emergencies, getting very sick can also make the sugar go up. So, it's really important for you to know what you're taking so that we can know how to kind of adjust you and help you with that. So, health maintenance. Anyone with diabetes should see an eye doctor. They have a special eye exam where they dilate and they look in the back once a year. Podiatrist ideally once a year. Dentist every 6 months. Daily foot exams every single day. That's pretty easy. Most of us shower every day. Even if it's every other day, you want to make sure to look at your whole foot, even if that means using a mirror. Wash them, dry them, especially dry in between the toes. Lotion, don't lotion in between the toes. You don't want any areas where you're going to have a lot of moisture. And always wear socks and shoes. Because you don't know when, if you have diabetes, that loss of sensation might start. And if you happen to be out walking on the pavement and it's hot, I've seen people get bad burns. So it's always good to have a layer between your feet. You might not notice if you stub something. So if you do have diabetes, we do recommend your foot is kind of always covered when you're walking out and about. And then I remember why I put that patient up there to remind me. Another thing you can always do if you're unsure about anything on your feet, when you go to your doctor, if you're primary care or if you see an endocrinologist, take off your shoes and socks. When they do your blood pressure, they sit you in there to wait for them. Just do it as a habit. Take the initiative so that they will look at your feet. We typically do ask to see your feet at least once a year if you're not regularly seeing a podiatrist. If you're seeing a podiatrist and it's winter, I'm going to let you, I know you're regularly seeing someone. But be proactive about it. In the summer months, if you have diabetes or you have a family member who has diabetes, maybe you're the person that's helping them go to the doctor, make them take off their socks and shoes. I can't tell you how many times I've unfortunately had someone and they're helping take care of their elderly grandmother or mother or someone, and they do help them with all the self-care activities, but they may not have looked down there. And then they take off their socks and their shoes, and we do find a small ulcer or a small wound that needs a little treatment to be healed up. And it's not because they're not being cared for, it's just that little nicks, things can happen fast. So if you're helping someone, you're taking care of someone, just go ahead, if they haven't asked you to do it already, say, hey, why don't you look at my feet? Okay. So this is where the complicated part goes in, and we're not going to spend that much time on it because this is really focused on just if you already have diabetes and some medicines. But I want to just kind of explain to you some general strategies about what we're trying to do to fix the diabetes, what kind of medicines, how they work, how effective they are, and what's some of the things that we think of when we're choosing different regimens for different people. So look at all this long list of really weird names. These are all drug classes. You never have to know them. You're never going to learn them. I didn't put brand names up there because I don't want anyone to think that I think one is better than the other. I do have some preferences, and if you come see me, I will tell you them. But I'm not going to list them up there. So what this is to say, and it describes the different kind of things, and you can look at them if they interest you, but I'll tell you in general, the general ways we're trying to get at diabetes. Some of the medicines make your own insulin work better. It makes your whole body more sensitive to it. Okay? And that's a very common one. I will tell you the name of metformin. Makes your body more sensitive to it. It also stops you from releasing your liver, which stores sugar, into the bloodstream. So it stops that. Because remember, the body is a thermostat. Part of the pancreas's job is to be kind of a thermostat for sugar. So it has both sugar and insulin. So when sugar goes too high, it makes some insulin. When sugar goes too low, it releases some sugar. And you go back and forth, and that's what the body does to keep you normal. So the body absolutely can produce sugar at any given time if it's noticing you're going too low, and it goes back and forth. Another thing that we do is we have certain medicines, the sulfonylureas and the meglitinides, and what they do is they just give a little kick to the pancreas. They force it to squeeze out extra insulin. Now, the problem with the last two things I just said, if you make zero insulin, there's nothing that medicine's going to do. You can take that pill all you want. If there's nothing to force out of that pancreas, it's not going to do anything. So it has to have some insulin reserve. It has to have some insulin left over. And the same thing with the insulin sensitizer. If there's no circulating insulin in your body because your pancreas has now unfortunately been fatigued and it doesn't make any, what is it going to make you sensitive to? Nothing. And then there's some other things here that stimulate insulin production in different ways. And this is a neat one, the alpha-glucosidase inhibitor. What it does is it slows down the way your body breaks down carbohydrates. It gives your body a chance. So it makes the sugar come out so slow that even if your pancreas works a little slowly, it can kind of get there. It can make enough insulin with time. Part of the problem with some of the ways that we eat foods is that they just, especially sugary foods, the sugar gets into the bloodstream so fast, the pancreas doesn't even have time to release enough of it before the sugar already spikes. And then it is harder to get down. So that kind of slows things down. So the problem when we're choosing between non-insulin, and some of our non-insulin therapies are injectables. So there are things that are injectable medications that are not insulin, but they help the body to respond better. And some of them deal with that problem that we talked about. It's another hormonal problem. I gave you half an answer about why you're always hungry afterwards. Some of those injectable medicines help with that hormonal issue to not have that constant feeling of hunger. It balances some things out. And then the other more common injectable medicines that everyone thinks about is insulin. So, over here, this little chart is kind of just my way of explaining to you why we talk about insulin a lot, why a lot of people get insulin. And it's not anything they did. And if you've listened from the beginning, you know that there's just some reasons. Some is genetic, that you're going to stop making insulin. Some is because your body's resistant to it. Some of it is just because over time, you might have a very mild form of diabetes. But if you are blessed enough to live with that for 50, 60 years, your pancreas might slow down and not make enough, the same way everything else slows down. So that's why insulin plays such a big role, because here I have, how much does your A1C go down when we give you these things? So when we prescribe you a medicine, we're thinking about we don't want you to have a lot of side effects, but we also want to know where you want you to go. So if you're starting with an A1C that is twice the normal limits, and we give you a medicine that's only going to bring you down more points, what's the point of that? We're making you pay that whole copay for nothing. We should use something that's going to get you all the way down to where you need to be. Insulin, there is no maximum amount of insulin you can give. I've given everyone from 4 units a day up to 300 units a day. So there is no too much insulin It's all individual. You don't really know what your body's making right now. So, everyone is making different amounts. So you can all have different amounts of insulin. And the good thing about that is basically, the more insulin you give, the more the blood sugar goes down. And there's not more side effects the more you give, because it's a natural thing. It's what your body makes. But unfortunately has some issues with being able to make it. We even give insulin when people are making a lot of their own insulin, but they are so resistant to it that they need even more than the extra that they're making. It sounds a little counterintuitive, a little bit weird, but they're making so much, they're so resistant to it that if you just flood them with insulin, some of that insulin will get in, and then their sugar will go down. So I have some people that are very well controlled, and they're taking 100 units with breakfast, 100 units with lunch, and 100 units with dinner, because that is what their body needs. And then we have, so the other medicines, as you can see, 1 to 2 points. That's all we get. We get with the one that I said at the beginning, the metformin, the sulfonylureas, we get 1 to 2 points. So if you're starting out with a 10, we might not get all the way there with 2 medicines. A general theory, if we've already tried 3 medicines with you, we're probably going to recommend that you add a little insulin to the mix. Once you're adding on a 4th or 5th pill, and some of those 4th and 5th pills are the ones down here that aren't that effective, that aren't that strong, that sometimes some people with just that little bit of diabetes, we actually start with those for a reason, So once you're down to taking 4 or 5 pills, that might be an indication that you're going to need something like insulin to be able to really get you to goal. So this chart is not for anyone to understand. I just want to show you some color patterns, okay? So the color patterns here are basically, here are all the different kinds of medicines we use for diabetes, including insulin. Here are the things that can sometimes go wrong, not in everyone, but in some people. But look at all that. If you see that sort of neutral, see it all says neutral, that kind of gray color, that is all the things. These are all the things that can go wrong. And look at all that, where nothing happens. We give you the medicine, there's no bad effect. Do some of them have bad effects? That's where you see the little yellow and a little bit of orange. So there are some stuff that we're talking about. Some medicine, some of the things that they do. Unfortunately, there is weight gain, but there's also weight loss with some of them. Go ahead. No, it does not. And actually, for some people, it is quite the opposite. It can actually save the organ to last a little bit longer. So if you are newly diagnosed, your body is actually sort of glucotoxic because you've never had any medicine and it's been so high for so long. It is literally exhausted, asleep, not working. Some of those people that are brand new, newly diagnosed, if we put them on insulin for about 6 months, we can actually let the pancreas recover and slowly take them off of insulin and transfer them on to oral pills for many years. The truth of the matter is if at one point your diabetes was able to get so bad where you did need insulin, of course there's a chance later down the line that you're going to need it again. That just shows what your body is capable of, that when things get really bad, you might need it, that your body can't keep up with the level of your illness. But for some people when they are first diagnosed, they need insulin just so their pancreas can kind of pick back up, and then we can take them off of it. So when your A1C, if you come in and it's the first time you ever had diabetes, it might sound crazy. You think, oh, I've never tried anything before. Why are they putting me on insulin just to start with? But if your A1C was 13, 14, remember the normal is 6.5. If we can just get you to do the insulin for 3 to 6 months, sometimes we have better chance of you not needing it long term. And that might mean a couple years without it. Now, that might not mean that we can keep you off insulin forever, but maybe we can transfer you on pills because we preserved a little bit of that function, and we can kind of keep you on pills for a couple years. Then we'll worry about if you're ever going to need insulin later. I'm very optimistic that there are therapies out there that are not going to make all these injections forever and ever, that you're going to have to do it. So, but for now, that's what we have. And there was a time where insulin did not exist. So you can imagine, as much as it's a difficult thing to have to take insulin every day, it was a very difficult thing for families who didn't have that option. So, yep. So certainly, if you have issues with those other glands, it can throw your diabetes out of whack. But that's kind of like if you have any other kind of chronic illness or any other kind of disease in general, it can throw your diabetes out of whack. So because diabetes is really a disorder of controlling how much fluid you have, how much glucose you have. Any other stress on the body, any other thing is going to make it kind of out of control. So it's certainly worth it we screen people usually once a year to make sure that their thyroid's okay, and check on other things for them, because if those things are out of whack, it does make it harder to control the diabetes. Yeah. And the reverse is opposite true, too, as well. So if your diabetes is really poorly controlled, it will actually make your other conditions worse as well. You don't heal as quickly from infections. You can get sick a lot easier. So this is also why part of the things that we recommend is things that are good to protect you from getting sick, like getting your flu shot, getting your pneumonia shot, getting enough sleep. All those things keep you healthy too. I definitely went over my time, so I'm sorry about that. But any
other questions that you might have missed?
Is there a way to do this thing, or you don't think
yes, there is. So there's two ways, and I'll get back to your question in a second. So there's two ways. Insulin resistance sometimes has some physical manifestations in the body. One of them that is very common is you'll see a thickening or a darkening of the skin here and under the arms and in the groin and in the different skin folds. So if you ever see people with those very dark signs here, and that's actually a physical sign that they have insulin resistance already. As far as if you make insulin, there's a blood test. We check a blood test. It's called C-peptide. It shows us how much insulin you're making. So that's a very simple thing, and that is a test that I run often. When I have someone that is on a lot of pills, like I was talking about, and I'm thinking about talking to them about maybe they need to start a little bit of insulin once a day to go along with that regimen, I will often check that and see, are they still producing? And that kind of gives me an indication, because if it's really, really high, then I can tell, oh, they're really resistant to insulin, but maybe these pills, maybe diet, maybe exercise will actually work. Maybe we'll give them 3 more months and really intensify those things. Because it's one of the great things about insulin resistance is it actually does have a natural remedy, which is exercise. So exercise will actually reduce your resistance to your insulin naturally. So the more physically active you are, the better it is. And when you do exercise, one of the other things maybe I should have mentioned is try to never go more than 48 hours without exercise, because all of that benefit from exercise, the amount that your metabolism kind of goes up, it lasts for about 48 hours and then it dwindles. And then you do more exercise and it brings it back up. So if you can maintain it up here by every 48 hours and keep it up there, you're much more likely to keep your metabolism healthy. Sorry, yes?
Taking metformin for a long time, does it mess up your kidney?
No. Oh, that's a great question. I should have mentioned that while we were talking. So, metformin is not what we call nephrotoxic. Nephro is just a word for kidneys. Toxic is toxic. So metformin itself does not damage the kidneys. It is not directly damaging to the kidneys. The problem is that the kidneys can be affected by actually the diabetes, and they can be injured and slow down. And if they slow down and they can't get rid of, so when you take a pill, basically your body kind of transforms it and it activates it into the part that does the job in the body. And sometimes there's some other stuff there that's just waste and it gets rid of. So you take the pill, it gets kind of changed and activated, but you have to get rid of the waste. And we get rid of the waste a lot of times through our urine. So if that particular pill goes through that system and has something that has to be excreted, you need to be able to get it out of the body. So if the kidneys are really slow, you can no longer have metformin because you can't get it out of the body. But not because it will directly damage the kidneys. So it is like you can take metformin forever and ever and ever, and it's not going to damage your kidneys. But if you happen to get kidney damage for another reason, either just aging, another illness, or because your diabetes unfortunately wasn't well controlled, we have to tell you, unfortunately, you're no longer a candidate for it because your kidneys don't work. And I've had a couple really unfortunate cases where I had a young man who had an illness with his kidneys from childhood, and he had to take a lot of steroids, and steroids are a medication that, unfortunately, one of the side effects is that it can produce diabetes and it makes the sugar go higher. So he had to take a lot of that medicine to treat his kidney condition. His kidneys were still okay though. I would give him metformin, boom, all his numbers would come down. That is all that he needed. It worked perfectly. Unfortunately, the kidney condition got worse and worse and worse, and I tried the insulin. And the insulin, the amount he needed, because he was resistant to it. So the metformin was making him sensitive, and that was fine. But his sensitivity was so low, and I couldn't give him a sensitizing drug because of his kidneys. So we ended up having to switch him over just because of that to insulin. And he ended up needing very high doses.
Of what? Of the metformin?
Of the insulin. No, the metformin was no longer an option. Yeah, because his kidneys didn't work from a whole separate issue. But.
I would like to ask you, okay, now, at night, I take metformin.
Okay.
And during the day, I don't urinate that much, but at night, I go 4 or 5 times.
Okay.
So, to me, my kidneys overactive at night.
Well, it's hard to say if that is what is going on or if it's just a habit. So it would have to know, like, what time of day are you drinking the different waters, and also what other pills are you taking. Some people are taking water pills and they don't even know it, you know. And if they're taking that too late in the day, that'll make them pee all night. You know, so different kinds of things. And then some people, unfortunately, it's just that not so much that they have so much to pee, but they just unfortunately get into this habit. And they wake up, and then once they're awake, they think, oh, I should go to the bathroom. And then they go to the bathroom. And then they go back to sleep. And they're not peeing that much. Like if you were to measure it, you know, but they just kind of, so you have to kind of look at what your sleep habits are, how much you're waking up. But metformin kind of has a, the effect kind of is like generalized throughout the day, so it's not going to hit you just then to make it come out overnight.
Now, I had a 24-hour urine test done.
Yeah.
My doctor, the diabetes doctor. And what it showed was that I went to the bathroom, or I put out as much urine in 8 hours of, during the day. 12 hours of during the day,
Yeah.
and 8 hours at night, and the volume was the same. So I just don't, like she was talking about, going to the bathroom every 2 or 3 hours.
Yeah.
And I'm wondering where's all this water coming from? And it's tiring because the next day you're
It does. It definitely does make you tired, and good sleep is a very important part of it. So there's some strategies. So I will say this, it definitely, if it's keeping you up every night, if you're waking up more than twice a night to pee, it could also just be that your sugars are not well controlled. And then that, in general, even though you're not seeing it during the course of the day, that might be because during the course of the day, your sugars might be a little bit better because you're walking around and you're active. But then at night, your sugars can just kind of go up and up. So it would be a good thing to kind of get a feeling for where your sugars are at night, because your body might be trying to get rid of it. It's sensing it's going up. And before diabetes, one of the first symptoms we know that happens with diabetes is often that you urinate more, because one of the protective mechanisms of your body is to try and get rid of it. And it gets rid of it. Once your sugar goes over about 220, you start to try and pee it out. So it could reflect not having good enough diabetes control. Again, it could be some of the other medicines that you're taking. And also some of the diabetes medicines that we prescribe make you pee more. So you might be on some of those, I don't know. They're kind of making you go to the bathroom a little bit more frequently.
Any other questions? No? Thank you, Christina. It was wonderful. Thank you, everyone. And for those who are not here, thank you for watching. There is one program that's coming up December 6th, and it's Wound Care on Your Feet. So as we talked about podiatrists, we have one of our podiatrists, Dr. Cicero, who will be doing a presentation on wound care, or just being aware of your feet, things that you can take care of. And that is at the hospital December 6th in the private dining room at 1 o'clock. So I hope to see you then. I will be here to provide some glucose screenings if you want to stay. I can check your blood sugar now. And again, I'm assuming not any of you are fasting at this point of the afternoon. But we can give you at least an idea, baseline number for you to kind of have. And then we have other upcoming programs that you can take advantage of. Thank you. Thank you, Christina. Thank you, Megan, from the Montclair Health Department.